Hello everybody, this is me Sitagliptin, and today we are going to talk about diabetes mellitus, specifically type 2 diabetes mellitus, which is the most common diabetes worldwide. So without further ado, let's get this started. Type 2 diabetes mellitus, or T2DM, is also known as non-insulin dependent diabetes mellitus, which is, according to my view, a misnomer because at some point in their life there is a very high possibility that they are going to shift towards insulin as well if their diabetes is not being controlled by oral anti-diabetic medications such as metformin. It is basically a chronic metabolic disorder, and many people are surprised to know that this is a metabolic disorder, and this encompasses endocrinology as well because insulin is a hormone and endocrinology deals with hormones. So characteristic finding in diabetes is a raised, moderately raised, or a severely raised blood sugar level, serum sugar level. And mostly it is due to insulin resistance. And sometimes it is due to insulin deficiency. Coming on to the epidemiology of diabetes mellitus, we now know that there are approximately 537 million adults that are living with T2DM, and every 10th individual thus is living with diabetes. So it's actually a quite surprising number. It's very high, highly prevalent disease, and its incidence is increasing quite significantly in children and adolescents. Part of it has to do with the sedentary lifestyle and zero to moderately low exercise. And T2DM basically uh, was responsible for one death every 5 seconds, diabetes or its complications in 2021. Blindness, uh, kidney failure, heart attacks, stroke, and lower limb amputation. These are the causes of death for people with diabetes. Well, not specifically lower limb amputation, but at that point the intensity of diabetes is way higher than normal. For example, patients can present with heart attacks, stroke, blindness, and kidney failure. And when we check their glucose levels, they're way off the charts. So T2DM poses a significant risk for various complications, which include blindness, kidney failure, heart attacks, stroke, and lower limb amputation. When we talk about the risk factors of diabetes mellitus, there are a variety of risk factors. So most importantly, family history. If you've got a parent or a sibling who has diabetes, then you are at a significantly higher risk of developing diabetes. Similarly, being overweight. If you are overweight, morbidly obese, or you have central obesity, by that the term central obesity means um, fat deposition around the uh, abdomen. This is a very strong risk factor. Physical inactivity is a strong risk factor. All right. A high calorie diet combining processed food such as sausages and canned food, sugary foods, mm, desserts, uh, other high calorie stuff, carbonated beverages, they are all linked with diabetes. So you need to be wary of that. Another risk factor is the increasing age. particularly after 45 years of age, the chance of you getting diabetes increases. Ethnicity plays a major role in the pathogenesis of diabetes. African Americans, South Asians, particularly Pakistanis, Indians, and Bangladeshis, all of them, and along with the Hispanics, they all have a very high propensity for developing diabetes. Association with metabolic syndrome, cardiovascular disease, PCOS, hypertension, and hyperlipidemia or dyslipidemia. All of these conditions also increase the risk of diabetes mellitus. So, talking about the pathogenesis, we know that two main things happen. One of them is insulin resistance, and the other one is beta cell dysfunction. Beta cells are present in the pancreas, and they're responsible for the production of insulin in response to glucose levels that are above normal. Um, Three major mechanisms can be thought of. Um, Increased serine kinase activity. Now, what exactly is a serine kinase? Serine kinase is an enzyme which is basically responsible for phosphorylation. And similarly, P13K, phosphoinositide 3 kinase, which is also responsible for um, phosphorylation. Uh, so, increased serine kinase activity in fat and skeletal muscle cells is responsible for phosphorylation of IRS1, insulin receptor substrate 1. This is not the International Revenue Service, so please beware. Um, Phosphorylation of insulin receptor substrate 1. Again, this is a part of the insulin signaling pathway, and we're not going into details because this is not the subject of the topic. Um, when we talk about the phosphorylation of IRS1, what exactly happens after that is that there is a decreased affinity of IRS1 for another enzyme of the insulin signaling pathway, which is known as P13K. Sorry, not P13K, PI3K, phosphoinositide 3 kinase. So we have increased serine kinase activity, phosphorylation of IRS1, decreased affinity of IRS1 for PI3K, which ultimately decreases the expression of GLUT4 channels. The GLUT4 channels are responsible for the uptake of glucose in response to increased glucose level. So when insulin signals these GLUT4 channels to take up glucose, they take up glucose and they shift glucose into cells. All right. So increased serine kinase activity ultimately leads to decreased cellular glucose uptake. So when there is more glucose in the serum, it is um, uh, actually due to increased serine kinase activity. Another mechanism of importance is that central obesity, uh, fat deposition around the abdomen, is responsible for the production or release of not the production but the release of increased plasma levels of FFAs. So free fatty acids are increased in the plasma, and this again leads to impaired glucose uptake into liver tissue, the muscle tissue, and the fat tissue. Amylin and its precursor, they are secreted alongside insulin, and accumulation of amylin or proamylin in the pancreas. This is responsible for decreased endogenous insulin production by some kind of feedback mechanism. We're not going into details, but these are the main models of pathogenesis, which ultimately lead to beta cell dysfunction or insulin resistance. When we talk about the signs and symptoms of T2DM, we actually come across a very popular triad of symptoms: polyuria, polydipsia, and polyphagia. Polyuria means increased urination or increased volume of urination. Polydipsia means increased thirst, and polyphagia means increased urge to eat. Um, Other symptoms include unexplained weight loss. This can be due to insulin, increased production of insulin, blurred vision, um, diabetic retinopathy, fatigue, lethargy, malaise, laziness, pruritus, itching. This happens a lot. There is poor wound healing. We have infections which last a little bit longer than usual. Increased susceptibility to infections because of the lowered immune system, lowered immunity, exactly. Cough cramps, and this can be attributed to diabetic neuropathy and acanthosis nigricans. This is black pigmentation, patchy black pigmentation across the skin surface. So the symptoms develop gradually. There is no such thing as a very acute symptom of diabetes. All the symptoms take years and years to develop. Most patients are asymptomatic. This is to be noted. This is a very high yield point. Patient may not present with any of the listed symptoms. Most patients present to clinic with gangrene of foot, with blurred vision. They can present with a heart attack, a stroke, things we learned earlier. Elderly patients may present with a state which is known as hyperosmolar hyperglycemic state. This is a hyperglycemic crisis. So the glucose level in the serum is increased to such an extent that it changes the osmolarity of um, the serum. So we call it a hyperosmolar hyperglycemic state. Sometimes patients can present with DKA, but mostly this is in T1DM, though in diabetes this can also happen. Diabetic ketoacidosis is production of increased amounts of uh, ketone bodies, ketoacetate, etc. People usually present with a fruity order. This is due to the ketones as well. So we have ketonuria, um, and overall the glucose in this case is extremely high. The serum glucose levels are extremely high. When we talk about the diagnosis, there are two basic, very important criteria which need to be met to classify someone as diabetic. First of all, the FPG, fasting plasma glucose, needs to be 126 mgdl or greater than that after a 75 mg bolus of glucose, which is also known as the OGTT, oral glucose tolerance test. If we measure the blood sugar after 2 hours of that OGTT, if it's above 200 or either 200 mgdl, then that patient can be classified as diabetic. However, I personally do believe that HbA1c is a very good indicator of a patient's diabetic profile. If it's greater than 6.5% or equal to 6.5%, then that patient had above average glucose levels in the previous 3 months. It's a very good indicator of diabetes. So increased C-peptide levels, they are usually increased in T2DM. This is one differentiating factor between T1DM, type 1 diabetes mellitus, which is the insulin dependent variant, and T2DM, which is the non-insulin dependent variant. C-peptide is actually a part of insulin, but later it is cleaved in order to form the actual insulin. So increased C-peptide levels normally mean that insulin is being produced in excess because it is resistant. So it is not resistant. The tissues of the body are resistant to insulin. So that is why C-peptide levels are increased in T2DM. In T1DM, they are decreased. When we talk about the urinalysis, we can have glucosuria if the clearance threshold is, you know, it's above that. The glucose level is above that 200 mgdl. We will have ketonuria in very rare cases, occasionally, and we can have microalbuminuria. Microalbuminuria is presence of trace amounts of albumin in the urine, and it is the first clinical sign of diabetic nephropathy. This is to be noted because it's a very high rate point. Talking about the differential diagnosis, it is very important to note that there are a bunch of disorders which can present with similar symptoms to that of T2DM. Glucagonoma, which is basically a tumor that produces glucagon in excess, can mimic features of T2DM. In fact, all of these can mimic symptoms of T2DM. Glucagonoma produces excess glucagon, which increases the amount of glucose in serum, which increases the production of insulin via feedback mechanism. And when there is excess insulin production and then it still continues to increase, there comes a time when pancreatic beta cells burn out, and there is ultimately insulin resistance. Somatostatinoma mimics type 2 diabetes because somatostatin is a hormone which decreases the production of insulin, and therefore it can lead to symptoms that mimic diabetes mellitus symptoms. MODY, maturity onset diabetes of the young, and latent autoimmune diabetes of adults. Both of them are very different from T2DM, but somehow share certain features, diabetes as well, because when there is autoimmune destruction of pancreatic beta cells, there is decreased production of insulin. This is what essentially diabetes is. There is insulin, but there is resistance to it. There is no production of insulin. This is what diabetes is. Type 1 diabetes mellitus presents similarly, although way more serious than T2DM. Gestational diabetes mellitus occurs in pregnant females, um, but it usually subsides once the pregnancy is over. If it persists, then there is a very high chance that it will convert itself into T2DM. Medication-induced diabetes, patients on corticosteroids have higher levels of sugar in the blood. Acromegaly, which is excess production of growth hormone in adult stages, can present with or mimic symptoms of diabetes because uh, growth hormone produces insulin-like growth factor, which is responsible for proper insulin function. So when there is excess production of insulin-like growth factor, it can have symptoms similar to diabetes because it can interfere with the production of insulin as well. Cushing syndrome is in excess production of cortisol. Cortisol can increase due to Cushing syndrome, um, a tumor that produces cortisol, or medications, for example, corticosteroids. In any of these cases, cortisol is linked with resistance to insulin or decreased production of insulin. So all of these can ultimately lead to insulin resistance or T2DM. When we talk about the management of diabetes, um, since it's a very vast disease involving multiple organs, there is a need to, uh, counteract at a multifaceted level. We can have lifestyle modifications in order to reduce our risk of diabetes, and similarly, if we continue these modifications while we're diagnosed with diabetes, we can actually control the progression of diabetes. First and foremost, weight reduction, balanced diet, which includes more protein and less sugar, less lipids. We need to exercise regularly. We need to cease smoking. We need to limit alcohol, and all of these factors, which come under the heading of lifestyle modifications, they are very important. And if we don't follow these modifications, no matter how much medications we consume, our diabetes won't be controlled. When we talk about the oral medications, metformin is the drug of choice until and unless stated otherwise in case of contraindications. Um, Other oral drugs include sulfonylurias, meglitinides, DPP4 inhibitors, um, SGLT2 inhibitors, GLP-1 receptor agonists, thiazolidinediones, and alpha glucosidase inhibitors, acarbose, etc. Um, all of these, they are responsible for decreasing insulin resistance, increasing the production of insulin, and proper glycemic control. And other drugs, such as the ones I mentioned, other than metformin, they are usually a part of the combination therapy, all right, along with metformin or insulin, etc. So, injectable medications include insulin, and combination therapies include one or more of the above. Talking about the complications, just like I said, hyperosmolar, hyperglycemic state, diabetic ketoacidosis, they can often be the presenting complaints of people with acute exacerbation of glycemic uh, index. Sometimes, due to improper insulin therapy, for example, you can get life-threatening hypoglycemia if there is an injection of insulin and you forgot it, that you previously had insulin, and then you go on to inject another vial of insulin, and then you can have a very life-threatening episode of hypoglycemia. And usually the patient uh, numbs themselves. They don't know what is happening, because they are almost gone into paralysis. They can't move their hands because the glucose is so low that their brain starts to phase, and ultimately it can lead to a coma and then death. That is very rare, and mostly this is due to improper insulin therapy. Some people can use insulin as a suicidal drug. So, late complications of insulin include the coronary heart disease, cerebrovascular disease, peripheral arterial disease, monkey bugs, sclerosis. All of these come under the heading of arteriosclerosis. Gangrene can happen, and this is due to ischemic uh, pathogenesis model mechanisms that underlie diabetes. We can have diabetic nephropathy, diabetic retinopathy, and diabetic neuropathy, along with diabetic foot. Diabetic foot is basically when we have ischemia in the arteries of the lower extremity, and there is necrosis of the foot. And in order to contain that infection or wound, what we do is we amputate the extremity so that we can limit the process of necrosis, that it doesn't spread into the whole organ systems of the body. Diabetic neuropathy again can result in tingling sensation. Those cough cramps, they can be due to diabetic neuropathy, diabetic retinopathy, blurred vision, diabetic nephropathy, microalbuminuria, and raised creatinine levels. Necrobiosis lipoidica is again a condition that is a complication of diabetes in very high diabetic levels. This condition happens and there is necrosis of body parts along with deposition of lipoid material. We have a fungal infection, mucormycosis, due to decreased immunity. HIV infections can occur, aspergillosis can occur. We have diabetic cardiomyopathy that can occur. Fatty liver disease, non-alcoholic fatty liver disease, is a complication of diabetes. We can have hypoaldosteronism and limited joint mobility syndrome, though diabetic arthropathy. All of these complications can occur as a result of diabetes. How diabetes can be prevented? It's a very straightforward rule. If you know that you are at risk, you need to prevent it. If you don't prevent it, you will get diabetes. So you need a healthy diet. All right, it needs to be rich in fruits, vegetables, whole grains, not the processed stuff. You need lean proteins, includes fresh meat, not the processed stuff. We don't need sausages, we don't need canned meat, none of that. Only the fresh stuff. We need healthy fats, a little bit of uh, butter to some extent, a very little quantity of butter, or what's even more beneficial is olive oil. So that is a very good oil. We need to limit the intake of processed foods, sugary foods, fizzy drinks, carbonated beverages, desserts, any of those things. Need to prevent it. We need to limit those things so that we can prevent diabetes. We need to exercise regularly. Um, we need to consider joining the gym. We need to work out, walking, jogging, cycling, any form of physical exercise is very good for controlling your sugar level. Therefore, we need to maintain our weight as well. We need to have our BMI in the acceptable range. Usually, it's between 19 to 25, anywhere around that. And we need to limit our alcohol and smoking desires, because they are very toxic to the body, especially people who are aged. They need to stop smoking and they need to limit their alcohol. Another thing is, since it's asymptomatic, they need to have routine checkups um, in order to monitor their blood glucose levels, so that silent diabetes can be diagnosed and then we can have a proper treatment scheduled. We need to manage stress. Stress induced uh, diabetes is very common. Most of the people, they have some certain incident in their life after which they start to have clinical symptoms or symptoms of diabetes. um, Stress reducing techniques such as yoga or spending time with your family members and friends or anything that suits you or relaxes you is a very good way of relieving stress. You need to have a good schedule of sleep as well. You need to know that our family um, is not diabetic. If it is, then we are at a high risk of diabetes, so that we can uh, better recognize what we should do and what we should not. So we need to learn about the symptoms of diabetes. For example, if we start to see uh, blurry after we are 40 and above, we need to be aware of the fact that this can be diabetes. Or you sense tingling sensations in your body, you need to have a checkup. Alright, especially if you are in the higher risk group. If you have a family member that's diabetic, if you're stressed, you don't sleep well, if you have central obesity, if you eat high calorie food, all of that stuff. So you need to be aware of that. This was about the prevention. Thank you for watching this video on diabetes mellitus type 2, and if you liked it, please give me a like and subscribe my channel, and do comment whatever your concerns are. I'll try to address them. Till then, bye.